Namaste. I'm Dr. Sapna Nangia, Director, Head and Neck and Breast at the Apollo Proton Cancer Center. Besides these two sites, I also look after radiation for skull-based tumors and gynecological malignancies. When discussing a patient who has benefited from technology or the importance of technology in gynecological malignancies, I would like to discuss a patient who received proton therapy for an endometrial cancer. Our patient is a 57-year-old lady, diabetic, who was investigated for postmenopausal bleeding and noted to have a serous adenocarcinoma involving the endometrium. After due staging, she underwent surgery, which included total abdominal hysterectomy and bilateral salpingo-oophorectomy, pelvic and para-aortic lymph node dissection with the usual assessment of the omentum and the peritoneum. The lesion was noted to be a serous adenocarcinoma involving the lower uterine segment, deep myometrium, lymphovascular spaces, as well as many as 19 out of 47 dissected lymph nodes, both in the para-aortic and pelvic regions. She then underwent chemotherapy, 4 cycles of paclitaxel and carboplatin. Following this, she sought opinion for proton therapy as the treatment technique to be used to deliver radiation therapy. Proton therapy is a specialized technique of radiation which limits the dose being received by the normal structures by using the physical characteristic of protons. So she underwent proton therapy under our care at the Apollo Proton Cancer Center, and a dose of 50.4 gray was administered in 28 fractions to the pelvic and para-aortic regions. Proton therapy allowed us to do was to reduce the dose received by the bowel by more than 40%, by the bone marrow by more than 20%, by the kidneys by 35%, and by the liver by as much as 85%. This meant that this patient was able to undergo treatment without interruptions and without any significant diarrhea, in spite of the fact that she had received 4 cycles of systemic chemotherapy prior to this treatment, and also in spite of the fact that she received radiation for both the pelvic and the para-aortic regions. And this is the power of proton therapy because of the reduction of the dose being received by the normal structures. Our findings match with the findings of Anderson et al. Of Mayo Clinic, Arizona, who have noted that patients undergoing proton therapy for gynecological malignancies are less likely to have diarrhea at the end of treatment and also less likely to have grade 3 toxicity at the end of 12 months following treatment.
I'm Dr. Kumar Gubala, Senior Consultant Gynecological Oncologist at Apollo Proton Cancer Center, Chennai. Ovarian cancer is the most lethal among all gynecologic cancers. Nearly 75 to 80% present at very advanced stage. We are actually a team of doctors taking decisions in tumor board and caring for patients. And we have all facilities to treat these problems under one roof. Evidence supports that maximizing the surgical efforts with radical surgery to remove all visible cancer can provide a survival benefit in patients with stage 3 and stage 4 ovarian cancers. We achieve complete site reduction in around 90% of the patients in advanced ovarian cancers, which is one among the best in the world. In recent years, cytoreductive surgery combined with hyperthermic intraperitoneal chemotherapy offered increased survival rates. In the same way, cytoreductive surgery with intraoperative hyperthermic intrathoracic chemotherapy, which is called HITOC, provides an alternative strategy to reduce the tumor load in the chest and prevent pleural recurrences. We recently had a 49-year-old lady who presented with breathlessness and was diagnosed to have a stage 4 high-grade serous ovarian cancer on tumor markers, PET-CT and biopsy. Her PET-CT showed ascites with extensive abdominal disease, pleural disease with effusion and enlarged chest nodes. She was later discussed in the MDT and the decision was made for neoadjuvant chemotherapy. She underwent chemotherapy very well and had 4 cycles of chemotherapy, and her PET-CT showed good response to chemotherapy. Post-PET-CT, we discussed her in the multidisciplinary team meeting, and a combination of cytoreductive surgery and HIPEC with HITOC was considered as an individual basis in this patient, as tumor seemed resectable.
I am Dr. Abhijit Das, Senior Consultant, Thoracic Surgical Oncology at Apollo Proton Cancer Center. Carcinoma ovaries are known to have transcelomic spread, In such cases, cytoreductive surgery along with high torque is commonly done for pleural metastasis which is spread from ovarian malignancy. But having both the pleural and the peritoneal metastasis at the same time is very rare. In such a scenario, you need to plan both the surgeries in such a way that it has minimal morbidity. Moreover, the chemotherapy dose for both thoracic and abdominal cavity needs to be titrated properly so that it does not have any additional side effect. It had to be a team effort between surgeons, medical oncologists and support staff to perform something which has not been done before in India.
She had a laparoscopic assessment, following which a couple of days later she underwent cytoreductive surgery. This surgery involved a laparotomy with en bloc resection of rectum, sigmoid, pelvic and right paracolic gutter peritoneum. She also had total mentectomy, appendectomy, pelvic, para-aortic and portal node resection, and also had right diaphragmatic peritonectomy with resection of tumor at multiple sites, and a rectosigmoid anastomosis was performed. She was given hyperthermic intraperitoneal chemotherapy before the anastomosis.
From thoracic oncology point of view, after the abdominal cytoreduction and HIPEC was completed, we had to make sure that the intraoperative vital parameters of the patient are within normal limit. After that, she underwent a thoracotomy, radical pleurectomy, along with resection of the central diaphragm, pericardial nodes, station 4R nodes, 7 nodes. Once we are sure that all visible macroscopic disease has been removed, high torque was done with a second chemotherapeutic agent. After the end of the surgery, which lasted for approximately 15 hours, she recovered well, and as the days moved on and she was discharged on post-operative day 10, we are all happy that we were successful in achieving the milestone.
Cytoreductive surgery and HIPEC should be offered in experienced centers where the morbidity is acceptable. Our morbidity is far less than when compared to the rest of the other centers in the world. This joint effort between the gynecological oncologists and thoracic surgeons helped the patient to have no visible residual disease, which is the key for survival in ovarian cancer patients. We jointly perform abdominothoracic resections on a regular basis for advanced ovarian cancer patients, one among the few centers who offer these services, wherein other centers without thoracic team deemed inoperable as there is no way to achieve complete removal of tumor. Even in stage 4 ovarian cancer, there is more to life.
Namaste. I am Dr. Prasad. I am a senior consultant in medical oncology at Apollo Proton Cancer Center. This case discussion is about the cancer care in elderly, and stage 4 cancer is not the end of life. Our patient in this today's discussion was an elderly, frail, 76-year-old lady who was diagnosed with ovarian carcinoma stage 4. She was initially evaluated in another hospital in a tier 2 city in southern Tamil Nadu and was diagnosed with an abdominal distension. Initial evaluation was done and she was found to have ascites and a tense abdomen, because of which she was not able to eat and she was very cachectic. Because of her very elderly age and her family members and the doctors in the smaller town in Tamil Nadu were not able to decide what exactly would be the ideal treatment for her. The family came to Apollo Proton Cancer Center and the patient was evaluated with a whole body PET CT scan. We found that the disease was originating in the ovary and an ultrasound guided biopsy was done and it was reported as serous ovarian carcinoma. As per the recent guidelines, her sample was sent for molecular testing and she was found to have a favorable BRCA1 mutation. Her case was discussed in the multidisciplinary tumor board in Apollo Proton Cancer Center, and the board decision was to start with chemotherapy to downsize the tumor and then to plan for surgery. She was started on a weekly low-dose chemotherapy along with targeted therapy as per the guidelines for her initial treatment. The team with the medical oncologists, dedicated chemo nurses, the clinical nutritionists and the family members synchronously worked together to help the patient get better. As she was continued on treatment on low-dose chemo with very less side effects, her nutrition had started to improve and she began to recover faster. Her disease started to regress and overall general condition had improved very well. She had completed 18 weeks of low-dose chemotherapy and she was re-evaluated with a whole body PET CT scan. She was found to have an excellent treatment response and then she was taken up for a cytoreductive surgery. Intraoperatively, the surgeon, who is the gynec-oncologist, was able to remove the residual disease completely, thereby achieving an optimal surgery. The final histopathology report had been reported as complete fibrotic tissue in the entire resected specimen, which is suggestive of an excellent response to the chemotherapy. She had recovered well after surgery and had subsequently started an oral maintenance therapy, which is called olaparib. Right now, she is doing extremely fine about 9 months after surgery. To conclude, cancer care in the current era of modern advancements has completely changed the way we treat elderly patients, stage 4 patients, and the cure rates are extremely better compared to yesteryears.